So the next lecture is mine, so we'll skip the intro. You're probably sick of seeing me up here, but I ambitiously took on 4 concepts I wanted to introduce to try to stimulate further discussion research down the road. So you forgive me if I move pretty fast through this presentation with a lot of information. So my practice, for those of you that aren't aware, it's Los Angeles, and it's very prototypical LA, where people really want to stay active, they need movement, they need motion. I term this vision, action, personality type. And these type of patients, activity is like a drug. It keeps them sane. You take away their activity, they get irritable. They need to get better yesterday. And these aren't just pro athletes playing for NBA teams. These are former athletes or recreational athletes. And so this is one of my patients who's a master's pole vaulter, and this is his response of his knees holding up following a series of PRP injections where he did 205-pound back squats, 1.5 times his body weight, and 1,000 stadium steps, which is much more than I currently do. This is a patient I'm currently treating who's a 79-year-old marathon runner. His name is Vic, and this was his email response just shortly after 2 PRP injections. I've been doing 50 barefoot hill repetitions daily, up to 50-meter hill regularly. His knee feels better biomechanics. Looking forward to his 3rd injection. So these are the type of patients, when they're active, and generally, sometimes I predict good responders more on how active they are as opposed to the radiographic findings, which has been poorly correlated in the literature. I like my patients active. I want to keep them moving. So this is just a slide of some of my senior athletes that are very active: pole vaulting, ballroom dancing, playing basketball, surfing, drag racing on salt flats, doing things that we really weren't intended to do, but keeping them active and happy. So in our practice at the Ortho Healing Center, we generally focus on 3 biologics, the 2nd and 3rd of which are autologous nature, which are PRP and bone marrow concentrate, although we do use a lot of hyaluronic acid. So I'm not going to go into the basic science of bone marrow concentrate. I spoke on that last year, and those lectures are available. But this is a great review article that we painstakingly published last year, which I encourage you all to get a copy of at some point, that just reviews the basic science of bone marrow concentrate for cartilage disease. I'm not going to go through the mechanisms of stem cells. We had the founder of MSCs here, which I was thrilled to have yesterday, so I'm not going to do any justice going into the mechanisms, but the slide info is here as well as in Dr. Kaplan's for you. So next is bone marrow aspirate, the procedure to remove marrow. And so we found after using fluoroscopy that ultrasound actually was easier for us with our comfort level, and there was a paper that discussed the use of ultrasound for it. And so there's a video showing on the side using the PSIS as a landmark and visualizing the needle, which you'll also see if you're participating in the cadaver lab, or this morning we're doing a live demonstration. We avoid overuse of anesthetics. From a TOBI meeting in the past, some research was presented that there may be cytotoxic effects of anesthetics, so we use diluted ropivacaine, which we'll discuss later. We pre-medicate our patients with Valium and Tramadol just to make the experience smooth. It's an office-based procedure for us. Our goal is we want people, whether it's PRP or bone marrow, we want from start to finish a 5-star experience where it's pleasant, they want to come back, they may need repeated treatments. We want them to recommend a family member or a friend, which is how we've grown and have a great community of patients. So from start to finish, everything is smooth, it's a comfortable process. The medications we found have been helpful in our experience. There's actually been published literature on it. We also use an automated power driver, which some studies suggest may help, and it's our preference to utilize that. This image is courtesy of our next speaker, Ted Sand. Thank you for sharing, which just shows the same premise of marrow concentrate as PRP. Through cell density gradient, you're isolating the buffy coat monocyte layer. So I believe it's critical to use musculoskeletal ultrasound for all injections. Some believe yes, some say, well, for the knee I can get into the joint, but many studies have shown that you actually need to use the ultrasound to visualize into the joint. And so here's an image on the opposite side where we're injecting in the suprapatellar recess. And sometimes you get synovial tissue or a scar and you think you may have completely aspirated that joint. And I feel like it's important to get that cytotoxic debris. And I believe there's an imbalance of the synovium, and that's what PRP's effect isn't really regrowing cartilage. You're just changing the biologic cartilage homeostasis. And so I really believe in using ultrasound for all of my injections. And this other image here is a rotator cuff, which you can see the needle directly into a cuff tear. And what's nice when injecting under ultrasound into a tendon is in a healthy tendon, you're getting resistance. And when you inject in a tear, you lose that resistance and your PRP goes in, which can be both diagnostic and therapeutic. And we use the same technique when we inject the meniscus in the posterior horn, where I'll lay the patient prone on their stomach, and then I'll take a needle and basically drive it through the posterior horn medial meniscus in the gutter. And once I get a loss of resistance, I found that tear. And so I emphatically believe ultrasound is critical for doing biologic-based therapies. It's hard enough to get our patients better. We don't want another variable of a blind injection possibly inhibiting the results. The videos just in advance are a tibialis posterior tendon sheath injection, a peroneal tendon split tear, an ATF ligament tear. So here you can see the peroneal tendon split tear, and my needle is in the center of the tendon. And again, you'll have a loss of resistance in a healthy tendon, and you can actually see the tendon fill with the PRP. And then at the top corner is an Achilles tendon in cross-section, and we inject inferiorly at the peritoneum, as well as you can see me going into the tendon, into the tear. And so here's my needle on the tear. So I'm going inferiorly and then as well into the tendon. And then this is an ATF injection of the ankle. Same thing, I get a loss of resistance where I'm going in, as well as the tibialis posterior tendon. And so in some cases, we'll want to inject directly into the tendon for a tear. Other times when I want a rapid response in an elite athlete, I'll inject the tendon sheath. For example, in that tibialis posterior tendon, you see it flow nicely. So to try to put this all together, this is just an example of our knee treatment algorithm. We start with a 3 Tesla MRI, which is important for us to get a baseline cartilage status. Dr. Gadadra showed the importance of using MR versus X-ray. We also look for those bone marrow lesions on fat-saturated proton density sequences, which are really important to us. We rarely use corticosteroid, except in the case where a patient comes and it's their daughter's graduation, they're flying cross-country, their knee has an effusion, they're in debilitating pain. But we explain it's very temporary and short-term, we need a plan B. We often start with hyaluronic acid. I tell the patient, let's date before we marry. If they, so to speak, have a virgin knee and we haven't done anything, why do we need to jump to bone marrow? Let's start with hyaluronic acid and see how your knee responds. We may find genetically, as I'll talk about biomarkers, some people may be more responsive to hyaluronic acid despite having advanced arthritis than we anticipate. We'll incorporate neural prolotherapy, which my colleague Dr. Affiero spoke about a bit, which are subcutaneous dextro injections to the superficial neurogenic nerves for inflammation. Then we'll consider a PRP cocktail, which is PRP and hyaluronic acid, and we use minimal red blood cells, leukocyte rich, however, neutrophil poor, at usually 3-week intervals. Otherwise, we'll consider bone marrow concentrate with a PRP booster, typically at 8 weeks. And then the last option, depending on their OA and what we see if they have loose bodies, we consider arthroscopic debridement, where we may incorporate subchondroplasty, as my colleague Dr. Gadadra alluded to yesterday, with the injection of calcium phosphate or subchondral drilling. In our office, we took the challenge of trying to quantify every patient. So we have data on all our patients where we get a baseline CBC and post-CBC. And we find great variability within the same patient as well as when the patient comes back at different times. So there's a lot of influences on your platelet count. But at least we're getting objective data looking at how well cells concentrate. Someone may have a low baseline at 100,000 platelet, yet get to 1 million or 1,000,005, where another may have a high baseline at 300,000 and only concentrates 3x. Whether concentration means anything is becoming more in question as far as the specific growth factor, but as far as being a clinic-based practice, this is the most cost-effective way we found to look at what we're doing. And we also look at our marrow concentrate with the monocytes to see how many fold increase we have. So next I'm excited to talk about our bone marrow concentrate data, which we crunched just before this conference. I presented at the ICRS in Bologna as well as another Biologics conference in Venice, Italy, and this is updated data that we're just able to present now. And so this just overviews our clinic data. We have an N of 125 patients we have data on at the Ortho Healing Center. And this divides the various subgroups, which vary from a toe to cervical spine. Obviously, knees were our most common, especially bilateral knees and single knees. Now, it's important to note, as you're a clinician, you're learning with research as you go, and we're always getting better at it. We had an N of 125, but we were only able to get data on 87 because we were missing some of the pre-pain scores on those earlier patients. So I'll discuss that later, whether or not that affects the data. But you can see the median follow-up is approximately 150 days. The age of our patients was around 57 years of age, was the typical patient we saw in the practice for marrow. The BMI was approximately 26. And we asked patients how uncomfortable was the marrow procedure. It's the most common thing you're going to get when you see a patient in your office. You mentioned, we can do PRP, we take your blood, oh, I've heard about that. The next option is we can take marrow from your hip and concentrate it, and right away about half the patients start rolling their eyes or looking a little like, are you serious? Can I really handle that? And so we collected data on our 125 patients, and we asked them 1 to 10, how uncomfortable was your marrow experience? And the median was a 2 out of 10. It's important to note there are a couple of outliers. It's sometimes like any procedure you can't predict, where we had 1, 9, and then a couple, and mostly zeros. But the overall median was 2. And so we explained to patients, you may feel a little bit. We're not going to put anesthetic into the marrow, which may inhibit the effect of the stem cells, but nonetheless quite tolerable. And so this is an important slide that goes over some of the data. And what we found was that the patient satisfaction of the 125 was a 8 out of 10, and out of the other group was a 9 out of 10 out of the 87. So generally, people were very satisfied with this procedure. And then when we asked them if they would repeat the procedure, we found 92% of the patients would repeat the procedure, and 95% would recommend the treatment to a friend. So again, the experience of the patient is very important. So as you're treating people, you don't want a reputation of torturing your patients, and they're not going to want to come back and send others. So this is perhaps one of my favorite slides, which just shows the median decrease in the VAS, which was significant. Our data 6 months ago, the VAS median was a 4, and this one is a 5-point difference on the VAS scale, which is really significant. And we looked at the percentage decrease, median decrease in pain was 71%. And my colleague Alan Mishra just explained, when we do studies for regulatory agencies and various approvals, we use 25% reduction in pain as the standard, maybe 50. But you look at the overall group of marrow, and we found 71% reduction in their pain. So these weren't patients that were getting maybe mild benefit. These were dramatic, game-changing benefits in people that had failed everything. We don't just jump to marrow. Marrow comes out when you failed PRP, you failed hyaluronic acid, you failed cortisone. Typically, you're the last hope. The patient comes to your office. I've seen 4 doctors. They told me I need a joint replacement. I'm 55. I want to ski. I want to stay active. Is this worth doing? So this is interesting, and this also changed as we had a larger sample size. The numbers are now statistically significant when we broke down the various areas of regions to see, is there any breakdown? Do some areas do better than others? And so what we found were bilateral knees had the most profound benefit. When we treated 2 knees on a patient, we found a 80% reduction in their pain, and these were statistically significant findings. We also found single knees had a 67% reduction. As well as shoulders did quite well. But in finding, we found that hips were our most challenging joint. And when I discuss with people around the room, it seems to be a universal consensus. Hips are tough. And we're going to have a little round table when we do the bone marrow demo. And I want to try to open that up and see if there's any insights, because we still had good results in hip at 50%, but that's not good enough. And so when a patient comes, this is an out-of-pocket procedure, they want your honest assessment, my enthusiasm is a bit tempered when hip patients come. We do it, but the problem is they come to us too late. They may be grade 4, and the data is suggesting they don't do well, whether their capsule's so tight, whether it's more biomechanical issue. For some reason, hips have been more challenging, and now the numbers are starting to separate out, where it seems that knees and shoulders seem to be doing the best for us, whereas hips are much more of a challenge that we'd like to work on. We looked at the role of BMI, and we actually saw a bit of an inverse curve. There's a slight correlation. We look for more numbers. But the data suggests that your BMI really didn't affect whether or not you succeeded from bone marrow. In fact, those that were a bit heavier actually had greater improvement in our data. And it was slightly statistically significant, and we're going to need more to correlate that. And so we figured, how could that be possible? And so we looked at the data, and we found that those with a higher BMI had a higher VAS score to start. So in theory, we proposed that they had more room to gain because they were in more discomfort at baseline, but more research is needed. But if anything, we tell our patients, we did the research, and you being overweight, it didn't have a negative effect on your procedure. If anything, lose weight, maybe there's more room to improve if you're an optimist. We looked at age, and this came up with Dr. Kaplan yesterday, and people asked, well, what about age? And we know that some of your regenerative stem cells continue to crank out your hematopoietic cells throughout time. And so the data showed no difference in your age. And we had a patient up to 79 years of age that had a good outcome. And so this was all statistically significant for us, and more data needs to come out there. But our data suggests, regardless of your age, you had a good option to do bone marrow concentrate, which is important because we're starting to see all types of patients, especially that senior level where they're 70 plus. They don't want to have a joint replacement. They may have some underlying comorbidities. They don't want the recovery time. They may have known a friend or a colleague that had a poor experience with a joint replacement. And so this is just some data to go off of. So the next thought was, okay, doc, you got 87 out of 125. Maybe there's something fishy going here. Is there some selection bias? And so we ran a statistical analysis, and we found there was similar in both groups on BMI, pre-injection pain, procedure pain, satisfaction, would repeat, and would recommend to a friend. There were some slight differences in that there's two physicians collecting most of the data, myself and Dr. Affiero. My data was more complete at 76% versus Dr. Affiero's patients were at 53%. We attribute that because Dr. Affiero does spine, and so some of these patients may be getting a spine bone marrow combined with a hip, which may be another player in their pain, so it was a little harder to get some of the pain scores on them. The differences in age were very similar at 55 and 58, which were just slightly different. As far as the median follow-up was 148 versus 167 days. So the conclusion was there was no evidence of selection bias in our subgroup. So overall, the conclude in our little early analysis, which we hope to publish, is that BMC may be helpful, but more long-term follow-up is certainly needed with controlled trials, much like when we started PRP years ago with a subgroup of 12. But marrow's been very encouraging for us, and I think more data is needed. And I think every one of us should have the responsibility of getting just even baseline. If you look at my study parameters, we have KOOS, modified Brittberg, and more, which we'll add. But just to get a baseline VAS on all of your patients getting PRP or bone marrow goes a long way. Then you can go back retrospectively and then get follow-up VAS scores, get satisfaction, and then you'll have some information for your patients. They'll respect that you're collecting data. We learn so much about what we do when we look at data, and some people don't come back to the office and you don't know if they got better or not. It's a great way as the clinician to really understand your work. So next I'm going to ambitiously go over a variety of information and some emerging trends in orthopedics and biologics. And so what you find in surgery, there's a significant increase in IL-1B, this pro-inflammatory cytokine response after arthroscopy. This was seen in ACI as well as microfracture. So while we're helping to form cartilage, or at least fibrocartilage, there's this milieu of inflammation that we need to figure how can we regulate that. So I'm going to talk about biomarkers, hyperbarics, and pulsed electromagnetic stimulation. Biomarkers is the thought of how can we use serum or urine or genetics or inflammatory cytokine levels to potentially predict or manage disease before imaging symptoms exist. So people may have some pain and your MRI is normal, but there may be something going on. We just can't see it with 2014 technology. And so biomarkers have been shown to change after ACL tears, causing this imbalance in cartilage homeostasis and may cause early post-traumatic arthritis. This was a study in West Point cadets where they looked at patients that are frequently injured with ACL tears, and they found correlations in their biomarkers. There was another study that looked at synovial fluid and arthroscopy analysis of ACL injured knees, and they found that 2 specific biomarkers, if you had them positive, you were definitely going to have at least 3 or more cartilage lesions after that injury. Can we predict arthritis risk? Well, at the ORC conference in Paris, there were biomarkers that shown to have some predictive abilities as well as to monitor disease for arthritis. Do our genes determine our fate? There's a lot of works in genetics. I encourage you to look at the poster presentation that goes over some of that, which is a lecture by itself. How about studying elite athletes for sports medicine in season? Can we prevent injury? Can we monitor cartilage disease? Well, at the University of Kentucky, they looked at their college soccer athletes and found certain cartilage marker turnovers that may start causing early arthritis. More studies are needed for that. Looking at biomarkers for ACL injuries, ACL is a fascinating topic in and of itself. We know ACLs are often injured from non-contact sport. There's genetic predisposition, hormone vulnerabilities, etc. If you have an ACL tear, you're likely 2 times likely to have a family member who had one as well. Can we predict ACL tears? Can we prevent them? Is there a correlation with biomarkers? These are all important information. Is there a risk of arthritis after ACL, which we know, and how do we pick those patients out? Most patients, at least 50%, are going to develop arthritis after having an ACL or meniscus tear. Can we predict risk of genetic markers for ACL rupture? Not yet, but genes are showing promise. What about Kobe Bryant? I just read yesterday in ESPN another baseball pitcher ruptured his Achilles tendon. You know, these athletes are worth millions and millions of dollars and spontaneously rupture without warning. There must be something we're missing. You know, most of these athletes, if you treat in your office, they don't have Achilles pain for months and then one day it snaps. It's spontaneous. It comes out of nowhere. There must be something we can't see that we can predict, and we need to work on that. So the conclusion are biomarkers are a potential game changer to prevent and monitor tendon and cartilage disease in elite athletes and active individuals. Also, as well as UCL and baseball players. I think that's a fascinating area for research. Next, I just want to touch briefly on hyperbaric oxygen, which many are somewhat familiar with, but it's the concept of sitting in a chamber and breathing 100% O2 for 2 to 3 atmospheric pressures for 1 to 2 hours. And it's widely used in various medical indications listed here. The mechanism of action is it rapidly mobilizes stem and progenitor cells from bone marrow and adipose to peripheral blood via nitric oxide-dependent mechanism. And speaking with Arnold Kaplan yesterday, it also may free off these pericytes through the body thinks there's some trauma occurring and it releases stem cells and mobilizes them. They amplify growth factor synthesis, promote neovascularization, angiogenesis, home to ischemia, and improve healing. All the stuff we're trying to do with PRP and bone marrow. Contrary to Neupogen or GCSF, which was alluded to the other day, this is an alternative way to mobilize cells with a lower risk of thrombogenic events, a stronger safety profile. So one of our colleagues, Stephen Tom, has been very generous in sharing his data and collaborating with us. And he did research that shows a single 2-hour session of hyperbarics doubles your stem cell output in your peripheral blood, looking at CD34 and CD45 cells. He found if you did 20 sessions of hyperbarics, you had an 8x increase in your stem cells, which is equivalent to Neupogen or GCSF, which may be prohibited for use in the US. He also found the ideal atmospheric pressure, which was 2.5, which did better than 2. And these are his studies, and there's a reference for his article. I encourage you all to explore hyperbarics. There's a lot of potential, but this just shows the 8x increase in your MSCs. So hyperbaric medicine is used in equine, and our colleagues at the Alamo Pintado Center, Dr. Carter Judy, kindly shared their slides with us. They've used hyperbarics. They put their horses, which are 5-star race horses that come from all around the world. They do bone marrow PRP. Every case generally gets hyperbarics post-injection, 2 to 3 treatments. And this is a new picture of their newest hyperbaric where they drop this crane in to deliver it. But you think it's of great expense and effort to put a horse in a hyperbaric. And a horse has no placebo. When a horse is hurting, they go by bone scan, and if the bone scan lights up, they need to fix it, and then they look for objective measures. So hyperbarics has potential. About the role of it with what we're doing some research into that as well, as far as the concept of prehabbing or pre-treating a patient before doing PRP, maybe increasing some of the cellular contents before doing an injection, or post-op. We treat a lot of athletes, and post-injection we love hyperbarics. Lastly, I just want to touch on pulse electromagnetic stim, which uses electromagnetic waves to stimulate cellular modulation and healing. There's plenty of posters on it. It was used initially in wound healing as well as non-union fractures. What's interesting is NASA is integrating next generation astronaut undergarments. So they're sending astronauts in space with PEMF, with coils to help with some of the ill effects of anti-gravity, including bone density loss, muscle loss, as well as immune response. And there's actually some decent data. I was at ICRS in Bologna, and I was blown away at all the papers on PEMF for arthritis that just hasn't made its way to the US. It's widely used in equine. It's been shown in clinical trials to preserve cartilage quality and thickness, reduce tears of cartilage surface, prevent subchondral bone sclerosis. It inhibits IL-1 and has a chondroprotective effect. It's been shown to potentially help with MSCs and differentiate into marrow stem cells. This is a study where they looked at guinea pig severe arthritis with doing PEMF treatment at 37 and 75 hertz. They found improved histological cartilage scores, avoided bone sclerosis with graded cartilage thickness versus sham. This is another treatment by Gobi et al., who has presented in the past at TOBI, and they did PEMF for 45 days and found 2 years statistically significant improvement. They found greater effects at 1 year, which weaned off, but was still better than baseline at 2 years with early grade 0-2 KL scores. In our practice, just wrapping up, you can never really predict a patient's baseline inflammation and whether they flare or not. So we recommend using, in our practice, we'll use cytokine therapy, which are homeopathic drops that we give the patients after injections in some cases to reduce a flare. If they have a real hot elbow and we're injecting and we're afraid they're going to be quite inflamed, we may want to regulate that inflammation. So we'll give them that, and it's quite well tolerated. We have various protocols for tendon and cartilage, and we've been using it for years, and patients really seem to appreciate it. I also just want to talk about the role of subchondral bone and bone marrow lesion. My colleague, Dr. Gadadra, mentioned it. It's really important to focus on the bone marrow lesions. Many radiologists don't even comment on them on your reports. We look at every MRI and really focus on those marrow lesions. They're correlated with joint replacements, limited function and pain, more than synovial effusions, and cartilage measurements. And if we can reduce those lesions, we can really accelerate healing. And it may be an important biomarker as well. There was a study that on elite athletes, mostly soccer players, with bone marrow lesions, they used IV bisphosphonates as well as vitamin D with earlier return to play. It's been shown obese patients as well as serum lipids may be vulnerable for bone marrow lesions. And patellofemoral brace, when worn for 6 weeks, actually reduced bone marrow lesion. So I prefer bracing, but minimally invasive bracing. I feel if it's going to reduce that marrow lesion potentially and keep people active versus, sometimes people feel the braces may promote atrophy, I like my patients moving. So again, post-injection, we'll often recommend bracing, and you can use whichever brace you feel comfortable with. I don't push it on patients. I say try it on. If you like it, get it. I find braces are like pillows and mattresses. Some people are really particular. What one likes, one doesn't. But 9 out of 10 usually end up leaving the office with one, feeling a bit better. So after an injection, I feel like it's a wound. I just don't want to inject a knee and they waltz right out of the office. See you later, doc. I feel like you're putting so much into that procedure, they should leave protected and a bit stabilized without causing back and hip pain. So I'll recommend these braces that are evidence-based to be effective. And the last slide I'd just like to add here for any of those in sports medicine, I'm a diehard Detroit Lions fan. It's like the bane of my existence. And I was reading the Free Press just before I came out here, which I painfully read every day. And this was one of our #1 draft picks. And he just describes, the lifestyle, the culture of an athlete. This is a #1 draft pick for my team. And he's on a diet of McDonald's and fast food and soda pop. And we see these athletes, they're great kids, but something's not happening where the teams aren't integrating the culture of an athlete, where you need to take care of your body. We're doing these treatments on athletes coming to our office, and they're nutritionally unbalanced. They're pro-inflammatory, and it's making it more challenging. And the concept of career extension, not only do you want to fix yourself now, but when you're done playing, we saw those data from Dr. Ants on NFL players with arthritis. So we really need to change the cultural concept of these athletes and their teams. So some critical concepts for professional organizations as well as athletes is biologics, biomarkers, nutrition, Sports psychology is blowing up, and hopefully next year we'll have some info at TOBI for that. Biomechanical risk assessments, and the concept of the athlete of career extension. Not only should professional teams invest in their own athletes, the athletes need to invest in their own well-being. Thank you very much. If there's just one question, I think just due to my video issue, I went a bit over, and then I'll introduce our next speaker. One question right there.
I'd just like to comment on your hip results and give you my own experience. In 2006, I started ultrasound-guided injection, and I do PRP and BMAC. I did a lot of cases, and I found that all my outcomes improved, but I still had the same sort of 50-50 with hips. Well, 16 months ago, I bought a C-arm and started doing fluoroscopic guided injection, and what I found is that with a hip injection, with fluoroscopy, the approach is identical, the entry point is identical, the target point is identical. You place the needle just like you do, same trajectory as ultrasound. When you go to inject, the contrast, most of the time on my first try, you see the dye pattern, it just travels along the ligamentous capsule. So the capsule is adhered down to the surgical neck. And I'm not actually inside the joint, and it takes quite a bit of fiddling around to actually get that nice sort of flash of the contrast where it travels through the whole joint. So I would say, that the 50% you were getting with the hips, I would say that's because it's ultrasound guided. And I don't know how to fix that with ultrasound, because it really just, I need the contrast to be able to, the ISO view to be able to see that nice flow pattern. But thanks for that excellent presentation.
Yeah, sure. It's a good point. That's what we're here for, to open up dialogue. I mean, usually when we do hips, we do the anterior joint space, and I'll use color Doppler, and I'll actually go through the joint, and I'll get good flow. And confirm it's not like we're just doing the neck and not really sure. We get right into the joint capsule. We've tried joint capsule as well as femoral neck, but that's a great point, and we'll bring it up at the round table if any others find the same issue, or we'll try fluoro as well. But in general, there's something about the hip we got to figure out.